Jordan, they keep you busy. You don't get much time off.
If you own one of their cars, they won't just give you a car to drive when you're leaving.
Who? The Alpha Company?
Yeah, they want to just give you a car.
What do you think I'm important?
You're a customer. That makes you important, doesn't it? I remember my uncle bought his first Porsche and he went to the factory to do the test drive. They sent one of their people with him. They all have 25 miles on them. Cycle around. He wanted to be the only one ever
Oh my
built
gosh,
his car.
stop that.
He's a funny guy.
So you bought
When
it.
I go to Maserati, I get on a tour of the factory and switch the cars together, literally walk on the factory floor. Yeah, it's a small operation. Pretty cool.
Where was that?
It's in Moden. They make
Next to the balsamic.
I don't know that. Lodenburg?
Yeah, balsamic vinegar.
No, I was thinking city.
That's M-O-D-E-N-A.
Yeah, you see, I don't go.
Actually, I don't try that. That was one of the new things that I was tired of. You know, I've always microwave. I'm trying to learn how to cook. So I actually am doing some cooking. I'm making mean Caesar salad.
What you ought to do is learn how to do a wok, because then you can cook all kinds of stuff. You only have to know how to use one tool.
Is that what you do?
Yeah, use a barbecue.
Yeah, barbecues are. That's the man.
But that limits your barbecue to meat pretty much.
That's true. You gotta be a carnivore. Not for vegetarian.
Or an omnivore.
Well, no, my next one was going to big truck, and then I got the South American one. But no, I don't, I plan on not skiing this winter. I will go to Connecticut in a week and a half. My wife's 50th high school reunion next week. Ours is 2 weeks.
How about you?
It's in New Canaan, Connecticut.
We went to the European
Close
meeting.
there,
We went to
Connecticut.
actually from
Everything's close.
Berlin to Krakow, which was kind of an odd, especially given the war situation, and then back to Munich.
Yeah, New Canaan is 40, 50 miles.
Yeah, they're all actually back in town.
27 lived there.
Kind of nice.
Are they back to work?
must be pretty close.
Yeah, the company. I don't know the area. I've been there
My second daughter got married this summer.
50 years, close to 50 years.
Yeah.
We're going to fly into
hospitals to see the Hartford cardiology service at the U.
The AV system.
He's from Turkey. I mean, he wrapped his. We had entertained Turkey for. I don't know what
No political discussion.
No.
I was just told
Let that go.
Yeah.
That job.
So his name's Todd. Yeah, he can do it. He is. He's a audiovisual.
Do you know Zoom? That system?
Yeah.
expensive.
Save money.
No or yes?
Yes, yeah.
Because the standard AV system is going to be down next week. They're rewiring the building. So the only way we can broadcast is to use Zoom. You know how to do that?
Do you know how to use
Zoom conference calling?
Yeah.
I mean, it's available. Yeah, we can use it.
Can you meet me next
through
week?
with it?
Frank knows how to do it, right, Frank?
Well, or David does work. David can set it up. Yeah.
All right.
Sign
I
one of
think
them.
David can help
We
us
chat
out
later.
here.
Everyone just has to have the app on the other end or get online for Zoom.
So then you need to get the app ahead of time.
Yeah.
Yeah,
So I think
this
just
is
start
our
playing. Get an email.
All right, why don't we get started? I hope everybody had a good summer. And I hope everybody got the schedule for this year. I haven't heard any complaints or anybody who can't do what they were assigned to do or wants to change a date. So hopefully there aren't any complaints coming. There are a couple of new people in the room. If you're new to us, I want you to come up here and just introduce yourself. Our new fellow. Huh? Don't be shy. Come up here.
Stand up.
At least stand up.
I'm Lorena, the first year fellow.
Where are you from?
I'm trained at Cincinnati Children's Pediatrics, and I'm originally from Colombia.
Where's your colleague, the other fellow?
She's on vacation.
All right, she's a fellow, she's on vacation.
The first week of
You come
school.
up.
My co-fellow is Alice. She is internal medicine. She trained in New York, and she is away this week, unfortunately.
And we have new faculty as well.
I'm Maite Della Marina. I look forward to meeting all of you. I'm AI trained. I came from UT Southwestern, where I was there for almost 13 years here building the immunology program. So I joined the Seattle Children's Immunology group. So I look forward to meeting all of you, and thank you for giving me the opportunity of coming at 7.
Well, thank you for coming. One other thing, just this is for Gary for the most part, because he likes these things. I was just at Niagara Falls. This is sort of show and tell what you did during the summer. And does anybody know where the water that goes over Niagara Falls comes from and where it goes?
St. Lawrence River, isn't it?
Goes out to St. Lawrence River.
Which lake do you mean? Lake Erie, Lake Ontario.
Yeah, it drains 4 of the Great Lakes into Lake Ontario, then out the St. Lawrence Seaway to the Atlantic. That's the only thing I learned the whole summer. All right.
Goat Island separates the Canadian and the American.
What's this?
Goat Island
Goat
separates the American
Oh, that's
and the
right.
Canadian.
Yeah, there's an island which the falls are broken up, and that's one of the smart people in this room.
I was born in Niagara Falls.
All right, we're learning more than we need. All right, Dr. Hill kindly has come all the way from Utah to give a presentation today, sort of his career and the history of immunodeficiency diseases, and I think it'll be very interesting, very helpful, basic information for all of us. So thank you for coming.
Thank you, Lynn, for the invitation. It's great to come back to Seattle. I did my residency here way back from, I think, when was it? It was 69 to 71. So I probably preceded all of you guys here, as a matter of fact. By the way, Monty Della Marina, who was at Texas Southwestern for years, she and I used to talk, once a month at least, about interesting patients and DHRs and things like that, because AREP Labs serviced them there. And it's great to see all of you. Many of you came from Utah, at least I've met a couple of people from Utah already. Great. And thank you again. I must admit, as I'll show on this next slide, these are the Tetons. We had a meeting up there for 32 years on immunology, microbiology, and infectious disease. And I loved it up there, and I fell in love with it. In fact, I bought a little cabin I couldn't afford. Nobody can afford anything in Jackson, at least I couldn't. And so I bought a little cabin over on the other side of the Green, Idaho. But this is a spectacular place. And interestingly, I taught medical students immunology for the last, I taught at least probably 30, 35 years to the freshman and sophomore medical students. And this is a comment, a statement made by Chevalier Jackson, who was a prominent professor at the University of Pennsylvania. And Lynn pointed out to me he lived longer than anybody he knew, 120 years.
Is that a typo?
There are some errors in my slides. I will admit that to start. Yeah. But I agreed with him. The main job of teaching medical students is to keep them awake. And, as I get older, I find that also applies to practicing physicians, including myself, for that matter. So I'll throw these up. And those of you who attended the meeting last night, a few of these slides I presented last night, but I'll try to go through those quickly. But this is I and one of the guys who ran my cellular and innate immunology lab. and the other tall one on the right is the one who does my research at ARUP Lab, Tom Martins. And so at 59 and a half years of age, they said, come on, we're going to go climb the Grand Teton. I practiced some in the Wasatch Mountains, and one beautiful, spectacular day in July, we took off and went up. It's not that hard to climb. It's 5, 6, maybe some places 5, 7. But it was a spectacular day, and we made it to about 1 o'clock or 12:30 to the top. Interestingly, you see the little marker there. Now, let's see, I use the mouse. You see the little marker there. It said, you got all the way up there, and it said, altitude, call this number, and we'll tell you what the altitude is. It's the only place I've run into that, to be honest. But it was spectacular. Coming down is kind of exciting because you got a double rappel where you put 2 ropes together, and it's a free rappel, as you can see there. Pretty exciting. And then we got to the bottom and actually stayed another day up there before we came down. This is the Middle Teton, which we climbed the next year, up Garnett Canyon, and we got in a horrible thunderstorm with lightning and everything. Going up, as you can see right over here, and went to the meadows. We camped at the meadows, went and climbed the Middle Teton Glacier the next day. Got on top, lo and behold, another thunderstorm with lightning, sleet. Unbelievable. In fact, every mountain I've climbed up there, we've gotten into at least some lightning and rain. That's the Grand. There's the middle. The South Teton is down here. This is on the South Teton, and that's my buddy Rick Wise, who is actually an incredible climber, an excellent guide, has skied most of the major peaks in the world. Was the first to freehill ski the Grand Teton from the back side, and he skied part of Everest. He could have made the whole thing, but it was horrible like 20 years ago. But Rick is a buddy of mine now. He was a patient, but wasn't anything wrong with him, so we got to be buddies. This is Mount Moran, which is a little bit south of the Grand Teton, a spectacular peak. It's like a big airfield up on top. You could literally land an airplane if the rocks weren't so big. Here's over at Yosemite, and that's me climbing. I didn't climb that spectacular peak. It was a little one right next to that they call the manure pile, so I didn't really do. Here's Rainier. Went up it with Ed Beasters. Unfortunately, it was really bad up top, and I didn't make it. I was going to try to go this time, but I couldn't get on with one of the climbs. They had to come back down, and I went around the next day and tried the north side, and it was terrible too. But I'm bringing all this up because what I did last fall was we took a 32-hour flight from here, from Salt Lake to LA to Gwangju, China to Nepal. And those are the Himalayas, which I've always wanted to go to all my life as we're flying in. There's the China Southern Airline as we get off in the airport. Here's the welcoming sign with the Buddhists on the right and the Hindus on the left. So let's get back to work. You're awake, right? Anyway, we're going to talk about Star Wars or the Body Besieged and go over different aspects of the immune system and how we work them up at ARUP labs. Now, Hans Ochs runs an incredible lab here, which I'm sure it's in pathology right now, but you have always had an excellent immunology lab here. At any rate, these are my conflicts of interest. The only thing I'm doing now is giving a few talks for Horizon Pharmaceutical, which makes Actimmune, which I happen to really believe in chronic granulomatous disease. And I work at ARUP, but it's wholly owned by the University of Utah. We didn't make any money out of it, I promise you, and still don't. But I love working over there and working in the laboratory. because it's so critically important to immunology. I mean, we can look at patients, we can try to decide what they are. If you don't have the immunoglobulins, you don't have the antibody responses, you really can't tell. So I'm going to review the major portions of the immune system, describe patients with defects in each one of the systems, and talk about the laboratory tests we use. Now, this was an editorial by Gene Stollivan, who used to be chairman of medicine at the University of Tennessee. He worked with strep a lot, which I've done a lot of work with, so I really liked him and appreciated his comments. He says we have a major problem in the training of physicians, an immune problem, that we teach them all the bacteria, all the fungi, every detail about parasites and so forth, but we teach them very little about how the body responds to it. And that's what determines the presentation and what's determined the outcome in the vast majority of circumstances. So I'm going to go over those things right now. I don't know, this is mainly for pediatricians or for people who are just having young kids. I have a guy who's head of IS at ARUP. He called me the other day. He says, do something for me, help. My two sons, one's 12 and one's 6, and they're sick all the time. You know, they get 2 or 3 respiratory infections every couple of months. And I said, good, you got normal kids, okay? Because that's what one gets. This was a child who had, you know, a respiratory infection every month, but was growing well, was doing well. The normal child has 6 to 12 infections per year. Unless you put him in daycares, because he goes up to 9 average at that time. You have to rule out structural and anatomic defects, of course, but immune deficiency is always a problem. The Immune Deficiency Foundation symbol is the zebra. Don't think about the horses and the donkeys and the moose in Wyoming. Think about zebras, okay? Foreign bodies, little kids who swallow peanuts, carrots, bacon, have recurrent infections in the same area. If you have a vascular abnormality or some abnormality in the lung, which I diagnosed in the Vice President for Health Sciences at the University of Utah, because he had a pneumonia. I treated him. He came back the next year with the same thing, and he had a lobe of the lung, which was was blocked off partially. We had to remove that. Breakdown of the barriers, fractures, skin infections, eustachian tubes, which are narrow and horizontally placed, recurrent otitis. That doesn't indicate anything, but you know, you're blocking that off with an allergy or a virus infection or something like that. Sinusitis. I mean, everybody I see has sinusitis, I think. Particularly in Utah, where all the allergens blow all over the place, and the smoke now, too, as a matter of fact. So those things can cause sinusitis as well as immune deficiency. So 6 infections per year. You can go as high as 12 and still be normal. Interestingly, if each infection lasts 2 weeks, which prodrome and catarrhal phase and recovery takes about 2 weeks, that's 12 times 2 weeks. That's 24 weeks a year. That's 6 months. That's sick half the time. And put them in daycare or something like that, and you're talking about 3/4 of the time in most cases. No question this happened. This is my oldest daughter who had a little allergy, like my wife had when she was young, had everything under the sun. And then my second daughter on the left, who's crazy like a dad, but she's also kind of tough, she never got anything, as a matter of fact. So right there in my family, I had it. My mother-in-law comes out, my mother-in-law and wife say, hey, what's going on? You don't know what you're talking about. You're an immunologist. It's very obvious your child has some immune deficiency. You better work him up, hurry. And so I got Jim Overall, who was an infectious disease there, and told him what to order, and got all these tests perfectly normal, as you might imagine. At which time I told my mother-in-law it was time to go home. And she did. And she didn't come back for a long time. That is my definition of post-infection. So, early on, 6 infections per year, middle age, 3 or so. When you get out to IH, it's supposed to drop way down. And then I had 5 grandkids, and man, did it go up. It went over 12 infections per year, I think. And it's still up around there because of the infections my kids are bringing home. This is Nepal. They picked us up at the airport. I've never been in such a crowded, complicated, unbelievable city in my life. I loved it, but boy, it was crazy. Getting through this with bicycles going that way, cars and trucks going that way, yaks, mules. There was a cop on every 5th corner. He had a flashlight and a whistle. There were no street lights, and the cop just stood there and said, well, I don't know what to do. And so we kind of wandered through there. Interestingly, they took us out. I went to a clinic the second day that one of my friends had started, that I'm thinking about going over and doing some volunteering at. And the next morning, they picked us up at 5 o'clock, took us out to the airport. We were flying from there to Lukla, which is at 9,200 feet. And Lukla gets clouds and it has a lot of mist and so forth, and closes down all the time. So here we are waiting to catch the airplane. The airplane couldn't take off, so they put us on a bus. They took us over, said maybe we can get a helicopter and fly in. So we got there. They couldn't get it. They got us on 2 or 3 helicopters. They couldn't take off. Control wouldn't let them take off, so they took us back to the airport. We went back and forth, I swear, 5, 6 times. They finally ended up feeding us lunch, and then they tried to get us on this old Russian helicopter with the oldest Russian pilot I've ever seen in my life. And they were putting us on here, and then they put 3,000 pounds of onions and potatoes on here. And then they tried to get us on, and the pilot said, wait a minute, he's sitting back there, he's saying, there's no way we're going to take off and fly through this, so you guys get out of here. So there we were again. Probably about 3 or 4, this true story, no kidding. About 3 or 4 in the afternoon, we went over and we got in that helicopter, and lo and behold, we took off, and we fly in, not to Lukla at 9,200 feet, where there's this little tiny airport, but we landed out in this field. It looked like a high school or something, where everybody was trying to fly in, and everybody was trying to fly out. And you can see, I mean, we had to weave through all this and all the clouds and everything. Hey man, you're 9,200 feet, you know. And finally landed. Then we had to hike up about 1,900 feet to get to Lukla, and it was misty and it was unbelievable. I thought I was going to freeze to death just walking up there, as a matter of fact, but we made it. Okay, Star Wars of the body. You have the humoral immunity with B cells making plasma cells, making antibody. And we have intercontinental ballistic missiles like IgM to protect your bloodstream. We have fetal range missiles, IgG, that are in your bloodstream but also protect your tissues. We have IgA, We have IgA, which protects the seas of the body. It shoots out like a Polaris missile from a Trident submarine and gets out on the surfaces and protects you from invasion. Then macrophages are like the big AWACS planes with the radar up and top, wandering through the tissue, making complement components which go out, butter up bacteria, lyse some bacteria, cytokines which the macrophages make, like radar and radio waves, to tell the rest of the immune system something's coming. Neutrophils, the F-16s, and now my students correct me, no, Dr. Hill, you're wrong, it's F-35s. I said, okay, go up there to Hill Air Force Base and see how many of them are taken off. You know, they've had all kind of trouble with the $50 billion plane. And, but I still see F-16s, F-35s, which got to get in there in 2 to 4 hours to clean up bacteria. You have a big abscess or boil or systemic dissemination. And then the T cells, the generals. Are any generals in the audience? The T cells, as you know, they sit back from the front lines. They don't get to where the battle is, but they send out a bunch of cytokines that control the rest of the immune system. So let's talk about some patients that I've seen in the last 44 years. And I started seeing pediatric patients, but immediately nobody else was seeing adults, so I started seeing adults too. I mentioned the only time I saw just pediatric patients was primarily at Children's Orthopedic, not Seattle Children's, Children's Orthopedic, okay, up there on the hill.
They changed the name.
I know. And I said, no, you can't do that. It's Children's Orthopedic. This is a woman that came down from Idaho. Look at her lungs. I mean, horrible. They thought she had pigeon breeder's lung. Turned out she had 5 episodes of pneumonia. 2 serious episodes of any kind of infection. You've got to think about the possibility of the zebra and the immune deficiency as a matter of fact. The hypersensitivity panel, immunodiffusion was negative. Look at her immunoglobulin. Normal 768, she was 60 on IgG, undetectable IgA, and low IgM as well. B cells had normal immunoglobulins and so forth. Biopsy, Terraville bronchiectasis, proliferating lymphocytes, and trying to make antibody in all likelihood. This is what happened after we put her on IVIG. She went back to northern Idaho. She was a school teacher, and as far as I know, she's done well, except she had 1 episode of enlarged lymph nodes, which were biopsied and were not lymphoma, and I think she's continued to do well since. So, sinopulmonary infections, sinusitis, you can see that's the percentage there. Otitis, pneumonia, 86% of people with common variable have pneumonia. And look, 1 to 10 episodes, that's several years back. I think we pick them up a little bit earlier than that. A lot of giardiasis, one of the worst pathogens and most frequent pathogens in these patients. 60% have diarrhea, malabsorption, giardia, as you can see, 2/3 of those have giardia. My latest problem is norovirus, which, boy, when one of these patients get it, it's impossible to get rid of. Really seriously bad. And then the other thing, of course, is they get big spleens from having so many infections. Surgeons get anxious and want to take those out. And of course, you got to watch for lymphoma, because maybe 10 to 15 to 20% get other malignancies and lymphoma. As you see, allergy is very common, and autoimmunity is very common. This, by the way, is my card, which I give all my common variable immune deficient patients, which basically says the patient has lowered immunoglobulins. If he presents with fever, chills, cough, etc., please get a chest x-ray. Please get a blood culture, a sputum culture. Treat them with IV antibiotics. Don't give them water and say take aspirin and send them out like most ER docs do. This patient has something serious. Pay attention. Okay? Sometimes they do and sometimes they don't. But all my patients carry this card, and I tell them how much IVIG to give. Because every time you get sick, if you have an antibody deficiency, you need IVIG. You need to be repaired. Now here, a bunch of monogenic models of CVID. I think there are about 18 or 19 genetic causes right now. TOSI, often associated with IgA deficiency. ICOS, a T-cell abnormality. CD19, CD81, CD20, markers on the surface of B cells can all be absent. And then BAFF, and BAFF receptor. We found more mutations in BAFF receptor lately in the 300 common variable immune deficient patients we have studied. And here's known causes. Interestingly, this patient was seen in Colorado, diagnosed with common variable immune deficiency. Came to us, I saw her at the VA hospital. She was having pulmonary infections and things like that. We got on IVIG and everything. She got norovirus. She kept having diarrhea, and I treated her with nitoxazide and everything else they had to treat this with. Nothing helped. And then she got a fungus in the brain. a neurologist was seeing her, and she passed away at about 32 years of age, okay? Turns out we had enrolled her in our study, but hadn't done the sequencing yet. And by George, she had a RAG1, recombinous activating gene 1 deficiency. That causes skids in little bitty kids. This was a 32-year-old woman when she passed away of it. So you got to think about all these things now that can be causing these infections, all right? Okay, here's another male, 16 years old, recurrent otitis, recurrent sinusitis. I mean, that's not terribly unusual. 2 to 3 episodes of pneumonia. Oh, better look for immune deficiency. He came in with this posterior pneumonia, his immunoglobulins, anything less than 250 or so. I used to have ARUP call it as a critical. Because if you're walking around with strep pneumonia in your blood, and you got a 250 IgG, you could be dead in 6 to 12 hours. And I have seen patients do this, to be honest. Okay, his IgM was okay, IgA, but his IgM was low. He had T cells, he had B cells. This is him. He now stands about 6'6". He weighs about 240 pounds. He's an engineer. He works on information systems. I said, please come help me fix Epic. He's a great guy. But he did, and this is where his immunoglobulins profoundly low, and wait, I'm going backwards, excuse me. Profoundly low. Interestingly, he got Giardia, and we treated him with 3 or 4 different drugs. I had him say 2 or 3 different infectious disease doc, and it took almost 3 years of treatment to get the Giardia, not so much out of the stool, but out of the biopsies on the bowel. They were actually in the tissue right under the lining of the GI tract. This is an interesting family. A 70-year-old lady that I had seen starting at about when she was 50 or something like that. Look at her immunoglobulins, profoundly low. And no antibody response. Put her on IVIG. She's on the right over here. Turns out later on, one of her nephews, her sister's sons, got severe CVID, and then another one got CVID, okay? We checked the mother, and hers were low, and she was like 40 or 50, and she was doing perfectly well, so we didn't put her on IVIG. These are, oops, I'm going backwards again. And here's a huge family that we studied. They had a deletion. We did comparative genomic hybridization, and she had a deletion of a gene which contains a whole bunch of different, I think 8 genes in it, and one of them was Icaros. We presented this at a meeting back in 2012, and interestingly, we wrote it up, submitted it, I think, to the Journal of Experimental Medicine, and they rejected it. Subsequently, a lady called me from the Rockefeller and said, hey, we noticed you published, at least you presented an abstract on this back when. We've found about 5 or 6 families who have mutations in Icaros. So let's go together and let's publish this. So we put it all together, and it came out in the New England Journal back in 2016. Icaros is a gene that profoundly affects B cells. These patients have no B cells. Interestingly, in that big family tree, some of the kids at 5 or 6 years old have no B cells, kind of intermediate immunoglobulins, but are still doing well. So we're watching them very closely, but I don't treat until they really start having infections, because IVIG can be dangerous too. But I warn them, and they all have my card, and they all know exactly what to do. This is Lucla. When we woke up the next morning after staying in the tea house, an unbelievable meal. I've never eaten so well in my life. I ate so much food, and my colleagues did too. And coming back, I lost 10 pounds when I got back down. Because we hiked, we hiked 3 or 4 hours at least every day in 1,500 to 2,000 feet. This is the runway at the local airport. When I saw it, I was kind of glad we didn't land. As a matter of fact. I would have rather hiked up 2,000 feet than landing on this. You can imagine what it's like going back down, though. You take off, and you go as fast as you can, and you drop like this. And you're just sitting there praying, come on, propellers, pull me up. And we made it. We made it. You see how you have to fly out there. Really exciting. So here we are in Kathmandu. Here's Lukla. We're going to go down to Pha Ding, and then we're going to come up. Oh, I can't see it real well. Namche Bazaar, Tingboche, Dingboche, Dugla, and then we're going over here. Where are we doing? Over here, we're going to Zongla, which is about 17,000 feet. We didn't go to Everest Base Camp because you can't see anything from there. You're under the Khumbu Glacier, and it's, I hear, sort of like a slum camp or something like that, so we didn't go there. Here's electrophoresis. This is immunofixation electrophoresis. Here's the way you diagnose it if you're getting no gamma back here. You say, well, maybe I do, in fact, have hypogammaglobulinemia, but that's not the way to do it. The way to do it is to measure immunoglobulin. I always do an immunofixation electrophoresis on any adult, however, because you got to look for monoclonal proteins if they're over 15 years of age. You can have a little MGUS, or you can have a myeloma that profoundly depresses the other immunoglobulins. So every adult should have an IFE, in my opinion. And that lowers the other immunoglobulins. Look how profoundly low those are. It's like your body says, hey, I got enough, shut that off. This is a nephelometer that we measure immunoglobulins, grade down to about 7 mg/cent. This one works very well, fires off the concentration to the computer. Here, interestingly, and you never could learn, this is an 85-year-old person who came in and had, I don't know if you can see that or not, but look at his immunoglobulins. Whenever you have 2 serious infections, think about immune deficiency. We read these out every day, and I swear I find people 70, 80, 90 years of age who suddenly drop their immunoglobulins profoundly. Okay, here's the trail going on down. Spectacular. Look at this is Amadabla up here, which is an unbelievable peak. And here's on the hiking trail. Immunoglobulins, IgG 1, 2, 3, and 4. IgG1 is 70%, has about a 3-week half-life. 2 is about 20%, has a similar half-life. And where most of your polysaccharide antibodies are, your Pneumovax and things like that. IgG3 is mainly viral antibodies. IgG4 is allergic antibodies and blocking antibodies that you guys raise with your desensitization. This is a Luminex instrument that we use to measure immunoglobulins. We stick the different pneumococcal polysaccharides on here, incubated in patient serum, and can measure 23 different serotypes at one time with a good dynamic range with excellent pre and post antibody titers as you see here. It's critical to measure the antibody response in these patients and be sure they can't make antibody to polysaccharides, Pneumovax, not the Prevnar, don't use that because it's got a protein on it, and to things like flu vaccine and to diphtheria and tetanus is what I usually measure. And that's for tetanus and diphtheria and Haemophilus influenza. And just shows you the pre and post antibody titers. You usually go really well with these immunizations in the normal individual, but some people don't do that. So quantitative immunoglobulins, an IFE in an adult, specific antibody production, B-cell numbers, and you can categorize these all down in the memory cells and naive cells, et cetera, and I recommend those be done on everybody.
Can I ask you a question?
Yes.
Do you think there's clinical value in measuring IG subclasses?
Absolutely, I personally do. I've had patients with IgG2 deficiency that the immunoglobulins were normal, and then you follow up with Pneumovax responses and they don't make it. I've had a guy get 2 pneumococcal meningitises who only had that. So I really do. Okay?
One other question.
Yes.
This family tree you showed us, you said these people had no B cells, but they had some immunoglobulin. What made the immunoglobulin?
You got me. I mean, it wasn't 0 B cells. It was 2 or 4. But then that drops off, and they, later on, they start to need it. Or maybe they're in the lymph nodes or something like that. I don't know. That's an excellent question. Okay. By the way, when my patients have allergy, and I just showed you IgE testing, I send them to Costco and get some Claritin. Because it's only from about 1,000, it's $12 or something like that. That doesn't work. I send them to Jerry Blight, who was at Mayo that takes care of my allergy patients. Okay, here's the yaks coming down, I believe, yes. Which they shoved us over and let them go on the outside so they wouldn't push you over the wall. Here's the swinging bridges that you have to cross periodically. And oops, back to immune deficiency, the complement system. I don't know about you guys, but every time I looked at that, I said, I don't understand what I don't know. Little do I know I'd really study complement later on. Complement C1 through C9 with 4 out of line. You got that, you're halfway there. The things on the end, 3 and 5, make the major functional components. The A parts are anaphytoxins, and the 5A's the attractant. The B parts, butter of the bacteria, okay? The antibody is like the little things you stick in the end of a piece of corn. The butter butters it up so the white cells eat it better, okay? And the terminal component's lyse. This is the alternate pathway that's triggered by complex polysaccharides, by endotoxin, by, interestingly, cobra venom. If you get bit by a cobra, you better know the complement system, okay? And it goes down and does the same thing. You have control proteins there, the Properdin system, okay? Total hemolytic complement, you lyse the sheep red blood cells. You can use rabbit or other red blood cells to measure the alternative pathway, but mainly we do an ELISA, in which we have aggregated IgG on the plate. The patient's serum is added, it triggers down C5, 6, 7, 8, and 9. Deposit that on the surface, and we have a monoclonal antibody with phosphorylated peroxidase attached to it. So we have a complement activity immunoassay, which you screen for, works much better than hemolytic complement, which is variable and lots of trouble. So complement C1 through 9 with 4 out of line. The 3A's and 5A's are anaphytoxin. The B parts are butter. The terminal component's lyse, and the alternative pathway works in the absence of antibody. There's amidopolon again. Prayer flags everywhere. And trust me, when you walk across one of these swinging metal bridges, you're doing a lot of praying, okay? I almost converted to Buddhism because of all of the flags, as a matter of fact. This is Namche Bazaar at about 11,200 feet, which was the largest place we went through. A little girl from Washington who had a salmonella infection, got a terrible facial rash, actually had C4 deficiency, got arthritis, and got nephritis. What happens when you can't remove antigen-antibody complexes from the bloodstream, which she got after her salmonella infection? And she didn't have any C4, very rare, and so they deposited in the kidney and the skin and in the joints. And so she had a lupus-like syndrome with this complement abnormality. Here's a little boy that I saw, had recurrent pneumococcal infections, had 0 total hemolytic complement, 0 C2. Very common abnormality. Mom was 50-50, father was 50-50. Older sister, asymptomatic at about 12, had no C2 either. So we immunized them up with the Pneumovax. We measured the antibody. We gave them some penicillin, or augmentin, or whatever to gobble if he got sick before he got in. And we've watched him very closely ever since. He's done pretty well. C3 deficiency, terrible pneumonias, recurrent sepsis, recurrent meningitis. C3 deficiency can be terrible. Used to be thought incompatible with life, but several adults have survived. And then the meningococcus, okay? Waterhouse-Friedrichsen syndrome. I think this came from children's orthopedics. Interestingly, with a Neisseria infection. Women at 30 years of age have gotten disseminated gonorrhea, as have men, with terminal 5, 6, 7, 8, 9 deficiency. Little boy with nephrotic syndrome, recurrent pneumococcal infections. They lose factor B and C3 out in the urine. C1 esterase inhibitor. You guys see this, I'm sure. I've seen a few cases of this. Familial, where the thing is, where C1 esterase is missing completely. Acquired, where they had lymphomas. And there's more recently another mutation that's been found. 3 causes of angioedema. There's now a product, an IV product, that's C1 esterase, but I think it's $10 million a dose or something like that. Very expensive, but it just came out. You guys probably were notified of this as well. So, early complement component deficiencies, lupus-like syndrome, C3, severe infections, 5, 6, 7, 8, disseminated Neisseria infections. 9, there was one guy about 80 years old who was found with OC9, but hadn't had much. I don't know how important C9 deficiency is. Sat at the tea houses, the meals were just unbelievable. This is a big monument to Tenzing Norgay, the first Sherpa who climbed with Edmund Hillary in 1953 to, I believe it's 53, to climb Everest. And here is Everest. This is Lhotse over here, which is closer to us. Everest is back here at what is it, 29,320 or something like that. There's another picture. This again is Lhotse, and this is Everest right here. Abscesses, boils, neutrophils. Interestingly, here's a picture in which they shot a red cell with a laser beam. Neutrophil says, wow, there's breakfast, it's going for it. But another neutrophil runs down from up here, gobbles it up. Interestingly, this other neutrophil, the frustrated neutrophil, turns over here and eats this perfectly normal red cell, which is frustrated phagocytosis, which you residents, when you, fellows, when you get ready to take your board exams, you'll go to the refrigerator every night when you're studying for those, just like these white cells. Abscesses, cutaneous candidiasis, aspergillus. This is leukocyte adhesion deficiency, where CD11, CD18 molecules bind to ICAM1. It could be missing, give you delayed separation of the umbilical cord, serious abscesses, boils, and no white cells in those lesions. Selectin deficiency described in several families where you can't even roll the white cells along the endothelium. So, interestingly, you can't bind to the endothelium and get out into the tissues. Okay? Little girl with leukocyte adhesion deficiency. Perirectal abscess. Shortly after birth, delayed separation of the umbilical cord. Appendicitis, terrible peritonitis from this. Interestingly, died at about 5 because we couldn't find a bone marrow transplant fund. That was before we had these big pools. A museum for the Sherpas. There's Rick and Evelyn, husband and wife, my buddies who Exum guides, and again, have climbed all over the world. Here that's Mingma Sherpa, who took us, and he's showing us in the museum all the utensils they used to make there from gold and copper that they harvested there. This is, I came to Seattle and worked with Ralph Wedgwood, as a matter of fact. By the way, Seattle didn't look like that, and the University of Utah didn't, the University of Washington didn't look like that when I was here. I think that's the big cancer building in front or something like that. But here's Ralph Wedgwood, who just passed away last year. Wonderful guy. I claim he's one of my mentors. He trained Hans Ochs completely. Just a lovely guy, one of the first people who really studied immune deficiency diseases. He is one of the original Job syndrome patients with abscesses, boils, terrible fungal infections of the nails, terrible nematoceles, and described it in Lancet. Job, so went Satan forth from the presence of the Lord, and smote Job with so boiled from the sole of his feet into his crown. If any of you take care of these patients, this is a beautiful description of them, and I've seen many. I worked on it here, trying to measure their inflammatory response, and trying. I had all kind of troubles, couldn't get it to work. Went to Minnesota to do infectious disease with Paul Quee and Louis Wanamaker. This is the University of Minnesota on the river there. That's the Mississippi River going down. By the way, I was born on the other end of it in Louisiana, as a matter of fact. It was colder in Minnesota than it was in Louisiana, though. You know that? Anyway, I went there, started doing chemotaxis, measuring chemotaxis of cells through a micropore filter. I was convinced the inflammation was wrong, and we did studies there. We did studies here with Hans and Dr. Wedgwood and Simo Klebanov, and here's where we got most of the patients with Job syndrome as opposed to normal. I still believe that. We still have a grant that we're working on. STAT3, has certainly come along, but Job syndrome, extreme elevation of IgE, Candida infections, staphylococcal abscesses. I think we first described the facial features of Job, bone fractures in those patients. We thought they had low interferon, and in fact, we treated some of those cells with interferon, and they worked better. We now know they have low IL-17, which we, with Hans and his fellow from Germany, third published, excuse me. Here's a patient that was referred down to me from Mayo. She had eczema, recurrent abscesses, boils, the typical facies. Here's her daughter who had the same thing. And in fact, Hans said somebody else did, but I think we first described the familial instance of this particular syndrome with a young fellow from Mayo who referred him up. We also presented this to the Clinical Infectious Disease Society meeting. So now we have STAT3 mutations, which came from Japan first, from NIH second, and from here, and with us and others third. And we're still continuing to examine what we can do about these patients. Rebecca Buckley, who described the hyper-IgE and calls it the hyper-IgE syndrome, said they didn't make antibodies too good. I've used, everybody will occasionally try IVIG on them. I've not seen a profound effect of that, but if I don't have anything else to use and they've got terrible lung disease, I do that. The STAT3 mutation, going higher up, here's a typical trail. If you trip and fall, you could be gone. There's no question there. And there's plenty of places to trip. And here we're getting higher and higher. And here's a typical Sherpa. And this can be anywhere from kids to 60, 70, 80-year-old people. Look how much this guy has on his back. It's just unbelievable. Worked with Paul Quee on CGD, and I talked about this last night, who found bactericidal defect in patients with chronic granulomatous disease. Here he is sitting out at String Lake after he gave a lecture at about 90 years of age. Okay? He's still going strong. He measured phagocytosis and killing and found the respiratory burst to be abnormal. We did NBTs at first. These missed autosomal recessive CGD, and so we went to the neutrophil oxidative burst, in which you get a striking increase in dehydrofluorescence when you stimulate with formamyristate acetate. A little boy with chronic granulomatous disease who got aspergillus coming out in his spinal cord, in his liver, in the skin, died at about 9 to 12 years of age. I can't remember exactly. His older brother had the same thing. Both of them died of aspergillus, and then we learned to start using Sporanox, or itraconazole, the prophylaxin. We started using interferon gamma in these patients, and these patients started to do much better, and most of mine have survived into adulthood. Here's an autosomal recessive, a little girl, at about 12 years of age, 8 years of age, got a Chrysomonas luteola pneumonia, very unusual organism, had a big broad DHR pattern, suggestive of autosomal recessive chronic granulomatous disease, and we know there are 4 forms of that now, P47, P67, the light chain of the big cytochrome up here, P22, and now a new form, which actually is somewhat less severe, GP40 NCF4 form of autosomal recessive CGD. They don't make hydrogen peroxide, they don't make hypochlorite ion, they don't make hydroxyl radical, and they get terrible abscesses. 65% are X-linked, about 25% are P47 deficiencies, NCF1, and another 5% of the other 2 main causes. And now there was a paper in the Journal of Clinical Investigation very recently, in which I think there were about 21 patients with GP40 NCF4 deficiency as well. A little patient with terrible pneumonia with Burkholderia cepacia had an intermediate peak, looked like autosomal recessive, but was variant X-linked because the mother had both normal and abnormal cells. There's that family, interestingly. And another sister was found who, in fact, was a carrier of that disease. Working with Carl Whitmer, I think I'll skip over this to get finished on time. We got a very rapid DNA melting method for identifying which exon is involved, and we offer a CGD panel, which has about 90% of the causes in it that we're hopefully going to be able to get back to you in 48 hours, but unfortunately genetics wouldn't do it that fast, but this is based on the melting assay. Here's a little patient with Chiari-Akagashi syndrome, oculocutaneous albinism, lymphoma developed in this little kid. He actually died of the lymphoma. He had giant lysosomal granules in his cells. They can't break open those granules. They can't dispense. There's myeloperoxidase in those, and this is the way one can make that diagnosis. Chiari-Akagashi syndrome, classic disease, oculocutaneous albinism. It's a big tip away. That's Lhotse again. Everest is not in that picture, but it shows you we're getting above the true line now. This is the glacier coming off of Amadablam, which, as you can see back there, is a spectacular peak. We ran into several people who were going to climb that one from Norway. Here's Mingma Sherpa. It gets pretty dusty up there above tree line, and the wind blows a lot, so this is where he is. These are our clothes. This is the one time we washed our clothes the whole trip. and they're hung outside like this. It's just spectacular. Cell-mediated defects, very briefly, severe viral infections, fungal infections. A little patient with SCIDs who probably was born and mother's lymphocytes lived across the placenta and gave him a graft versus host reaction with a desquamated skin rash. He had Canada in his mouth. There's a patient who had SCIDs who got varicella and chickenpox and passed away from that. Here's where we used to test. We hardly use these anymore at all. We examine all the cells, as you know. We call it a T-cell extended assay. Lymphocyte subpanel 6. This is a screen for SCIDs in which you measure T-cell excision circles. When you rearrange the T-cell antigen receptor, you cut that out, and we have a little molecular assay that we can do that very rapidly. We pick up SCIDs patients. We screen the whole state of Utah and a couple of other states for a while. The state health department just took it back over. But it's very important to pick these patients up very early and transplant them. Here's a PHA with PHA kinase, pokeweed, mycotin, Canada, and tetanus. We stimulate those. We do those all the time. Here's a new flow assay, which I think Mayo's has been offering this in a partial form for some years, but this is using a component, EDU, which is incorporated into the cell, into the DNA, and when you stimulate it, it shows an increased fluorescence with this fluorescent labeled DNA component. And you can see going from here to here, this stimulation with proliferation. Here's T cells, proliferation over here, and over here with B cells, proliferation going this way. And you can do this by flow cytometry. We can use Canada, we can use tetanus, we can use anti-CD3 now in this particular assay, and we'll be online in the next month or so. This is lymphocytes, T cells. We can measure individual cell proliferation. We even started measuring B cells this way, and are looking at common variable immune deficiency, stimulating their B cells with antigens and mitogens, and seeing if they can proliferate appropriately. Okay. Oh, let's go through this real rapidly. This is just measuring cytokines. We measure a whole panel of cytokines. The people are using NIH is using it on spinal fluid and in what is it, cryptococcus meningitis, I think. We're doing a whole bunch of cytokines from a lot of patients. So to wrap things up, document the nature and severity and timing of the infection. Family history is absolutely critical. Careful physical exam, looking for evidence of these infections. I see a lot of immune deficient patients who I call psychoneuroimmunology. I'm not convinced they have any immune deficiency, but they are. And so I really work these up carefully. If I can, I send them out to exercise, because that seems to help them as much as anything, like with chronic fatigue syndrome, as a matter of fact, which is about the only thing that seems to help chronic fatigue syndrome, along with antidepressants and things like that. I check humoral immunity with the IFE, the immunoglobulins, the vaccine responses, and maybe subclasses if I don't find anything with those. I do that second, by the way. Abscesses, I check for CGD. I may check for leukocyte adhesion deficiency, particularly if it's delayed separation of the umbilical cord. Obviously, if there's some kind of albinism, I will check for myeloperoxidase. Cell-mediated immunity, I'll do the T-cell extended, a whole panel of those, and I'll do the flow assay and the lymphocyte antigen. My third daughter, she was kind of right in between the others. This is over in Aspen, Colorado, by the way. And they grew up, and they're still doing good. So every patient with a severe infection, you need to think about immune deficiency, and you need to study those. Now, if anybody has to leave, I understand that, but let's go on and show a few more slides of getting higher on the mountain, okay? Everybody's paying attention now. See? This is getting up high. This is Pelosi. This is about 23,000 feet, I think. This is one that one of our friends from the Teton first climb. Pretty spectacular peak. Pretty good climb, right? Unbelievable. Here's when we got to the highest. This is the Zongla. And then we went up above and climbed a little peak. So we can say we got on top of something. And this is coming back down. Here comes the mules. Mules, yaks. These caravans were just constant. That's the only way they can get things up there, except for that old Russian helicopter. I don't think he gets up there very, very good. Beautiful places. Last day, as we come back into Lukala, rain. That's the only day we had rain. Unbelievable in October. And it really got wet there, but we got home. Next time when we got back in Kathmandu, we took off on that runway. Very excited. We made it. And this is the monkey temple that we really wanted to go to in Kathmandu, where you have monkeys running around all over. Very high coming back. That's what a lot of the trail looked like. And again, you wouldn't want to fall off. My wife and I, in front of our cabin, over rigs. Well, my little cabin, that's my Volkswagen camper that I drove all the way from Minnesota to Utah in, and it's still running. Okay, still running good. And the cabin, we have some trees and things there now, but pretty spectacular. This is from Fred's Mountain up at Toryi, just above us, and that's my grandson. And that's when he was climbing about 5, 6 years ago. He now stands 6'2" and looks down at me, and is climbing with me and Rick up in the Tetons. So with that, let's stop. And I'm sorry it's 8:02, but we covered a lot of mountains and a lot of immune deficiencies. Questions?
Thank you. That was a beautiful review. For a short time, I'll remember some of that.
Any questions from the audience out there?
Yeah, you ran out of time, I'm sure, but so the TLR assay that ARUP offers, what are your thoughts on that? Do you use it?
I had it in one of the other talks I sent you, but I had to take it out because of time, obviously. That's what you do when you've done everything else and everything else is normal. And you've had unusual people like sepsis, unusual viral infections, herpes encephalitis, and things like that. Then you do the total receptors and you stimulate the mononuclear cells with a variety of total receptor stimulants. We do about 9 of those. And, we do a reasonable number of them, and we picked up a couple of people, particularly with NF-kappa B2. What is it? Wait a minute. I'm blocking it. I'm sorry.
With Nemo, I think.
Yeah, Nemo.
Where
Nemo.
Usually.
Nemo, and the one right before that, I believe, we picked up a couple of those patients. They're awfully rare.
Yeah.
We've kind of worked with Jordan Orange, who first, I believe, published this particular assay. We've also looked at it in neonates, and they have very low levels, as a matter of fact. You measure cytokine that you stimulate with the total receptor stimulants. But there are some patients who have them. Now, what you do about it when you get it, most of them, interestingly, will do pretty good when they get older. So if you can get them through the younger stages. For instance, IL-4, total receptor 4. Total receptor 2 deficiency can give you recurrent pneumococcal infections. Control receptor 4, I think, can give you endotoxemia, sepsis as well. Control receptor 3 gives you recurrent encephalitis, herpes encephalitis. It's a complicated field, and you have to reflex from those screening assays, just like the DHR, to a molecular assay. But always consider that too when you're at the end of the line and you have still no idea what's going on.
Well, thank you so much for coming.
Okay.
Really appreciate it. Thank you. Kept us all awake.
It's delightful to come back. To interact with all of you. Thanks for
I'm just going to say that it brought back some memories that I worked with Ralph.
Yeah.
Good. You guys had a good time? Did you get some time to go up to the trail?
I didn't take the tram.
No. Okay, perfect. Yeah.
exactly.
Right now, I just
Okay, because I want to email you to get your nurses, infusion nurses names.
I missed dinner last night.
I'm with Shire.
Right.
And I work for Harry Hill. I couldn't go with you. 22.
Great to see you.
Yes. Oh, yeah. So I have some background. Okay. Yeah. So he sort of trained me one way or another. I've learned other things as I've been out. Was it good?
Yeah, it's complicated.
I started with him in 1981. So.
I don't think.
Okay.
Yeah, and I'll keep an eye out for
Okay.
our two infusion nurses.
Yeah, so Scott did the oh no, that's all right. So here's a guy coming from out of the country.
I'm following you on the screen.
Basically, that he can.
So, did you get that in 1 year?
You have to sort of, it's very shaky, and I'm not sure that I would have taken it either.
Yeah, I didn't know that.
So, that, I think it's just, it's unfortunate. But I don't know. Well, and live year to year, and supposedly then after like 3 years, they can transition.
Is that okay?
So I think, in terms of submitting it.
Everybody likes you, everybody wants to keep you on board, but there's no money for you. I mean,
Sometimes like in December, it's
so that is, it's their own fault. We shut ourselves.
all right, good to see you.
Things go well. Yeah. Yes, I could make dinner last night.
The analysis sort of is where it is.
That's good though, right?
Did you stand in Washington?
We're waiting.
Things go well. Yeah, I mean, we kind of finding our new niche, with the bone marrow being so successful.
It's kind of all cool.
Country. But we think we still have a lot of patient lead into BMT.
Yeah, no, I'll take care of all that.
What you could do if you want to have internal meetings.
And it seems like a lot of the clinics are hospitals are doing that. Some still are shying away from BMT.
Do you want a copy? Should I create?
More success.
Do you prefer? Yeah. So a dark one or a
Yeah,
honey?
dark.
Yeah, it's interesting. Yeah.
We have a new bio.
I hope that was okay.
It was better than okay.
Yeah. Okay.
All right.
Take care.
I tried to combine the outcome.
How are you?
I did take it out, yes, with family pictures.
What age were you?
Hi, how are you?
Which one?
I work.
Well, two things. I need you. I need to talk to you. Oh, yeah, Vicky, I know.
There is
Anytime.
Yeah.
Just call me at 2 o'clock.
2 o'clock, right? Okay. All right. I'll be doing
We all
cell.
enjoy
How do you
your
report for what you're
global rescue.
I think I do. I just double check.
Helicopter, we all if you have a big problem. And we also don't.
What's that?
which gives you in the U.S. and it gives you local.
No, this is another patient.
And you're partially.
Yeah.
Yeah, that's right.
No, this is a different. This is a different one. There's that one. That girl's gonna be. She's sitting. So I talked to her a little bit. So yeah, so she's off the table. So,